Okay.
All right, you can see that?
Yes, I can see it.
All right, very good. And I'm gonna make it full screen, and then I'll start back off. Were you able to watch the lecture I did post?
I
Oh yeah,
about
you already had this. Yeah, so you're good.
okay. Yeah, yeah, yeah.
Yeah. All right, because we were talking about the chambers and the valves and stuff like that, um, and then I posted this video here. If you get a chance to watch it, it's amazing. It's excellent, and
Yeah.
I highly advise, just as a reminder, like run through. We were talking about the vascular system and how the heart has its own supply and of blood, that it doesn't rely on like the rest of the body. It has its own, and because of that, it has issues with, if it one of these things get blocked, we're in trouble, because that means the heart, like this, an occlusion, the heart's going without oxygen. It's going without the blood and the oxygen that it needs to continue to live, the tissue, because without that oxygen, our tissues will die. And then that's where we call like a heart attack, or MI, myocardial infarction.
Cardiac infarction.
Yeah. And then we were going to start the conduction system. The conduction system, a lot of times people, they're just like, well, I don't fully get this. Okay, so I like to make it, why? And of course, I don't have my picture on here. Like, let me make sure you can still see.
Okay.
All right. I like to look. See what we're looking at here. This looks like a good picture. Let's see if it stays that way. I wish it was a little bigger. Let's see. All right, so this is, and you can see my heart here.
Yes.
All right, excellent. So what we're looking at is we took the heart, we cut it in half, and we were giving a cross-section view of it. So our pacemakers, what their job is they are, I like to call them the conductors. If you have a symphony or an orchestra, they are the ones that go up, and stand in front of everything and conduct and do the whole performance. They lead. Well, our SA node, that's what we call it, the pacemaker. It is the conductor. It is the one running the show. So it is the main source of electrical current and activity. It is what tells our heart and gives it the energy through the signaling to say, hey, let's beat about 80 to 100 beats a minute. So
Okay.
the SA node is the main conductor. Now let's say something happens and some type of illness or injury, something occurs and the SA node craps out. So
Yeah.
now what do we have? We have a backup,
Okay.
because our heart's really ingenious. We have what's called the AV node, or the atrioventricular node. It's a backup, and if you see here, it's all connected all the way down and through here, and everything's connected. This one right here, as you can see, is telling it, hey, telling everybody what to do. But if it fails, we've got this. But
Uh,
our beats per minute are going to be less, and we'll go over that in just a second. Now, if, say, worst case scenario, this craps out, we've got what this area right in through here is the bundle of His,
okay.
and what we call the Purkinje fibers. And it was named after the doctor who discovered them. And the Purkinje fibers is our last fail, oh no, the poops hit the fan, it's all going down. So, but
Yeah.
it'll still give us a tiny bit of beats per minute.
Okay.
So it is the fail safe, the very last mechanism, if that makes sense.
So if
And, uh-huh.
sorry. So if all of those fails, that causes a myocardial
If,
infarction.
well, if all of these, wait, Where was I? Ah. Well, if they all fail, you have cardiac arrest.
Okay.
There's no heartbeat whatsoever. All
Okay.
right. So, and then that would be, a lot of times people misunderstand that. They associate a myocardial infarction, a heart attack, with cardiac arrest. They're completely different. During a heart attack, even during what one of the rhythms we'll talk about later, ventricular fibrillation or VFib, we still have electrical activity. So that's why later we'll learn that's one of the ones you can actually shock. What you see on TV when it's a straight, flat line, that means there is zero electric activity, and that's called asystole. And we don't actually, in real life, I never as a paramedic seen anybody shock asystole. Okay, so that's a TV thing they do, clips and bringing them back, but it doesn't work because there's nothing there. We shock people to try to bring this, to wake up the conductor and tell them, hey, get back at your job and start beating right. And a lot of times it works, especially if we catch it right in the beginning. So, and this is what like I said, talking about those nodes. So you would want to know the three nodes that we're talking about. Okay, is the SA, the AV, and then the bundle of His Purkinje. Okay, so and here's where this is. Your SA node is going to be, like I said, the good heartbeat, 60 to 80 beats per minute, and some people even run 100 beats per minute. That's all right, as long as it doesn't cause them symptoms. Now, when you start, like I said, the next, it'll be under 60 beats. So if the AV has to kick in and take over, you're going to be 60 beats. I believe it's to 30 beats per minute. And then say if it kicks out, all right, and the Purkinje fibers have to come in, we're talking like 15 to 10 beats, okay? Really, really low. So this is why I was telling you there, it's a fail safe. So it's sort of like having generators, backups, all right? So make sure you know your SA, your AV, and then the whole bundle of His Purkinje fiber. I'm not going to break these down just separately right now because it's just not, if you go on to nursing or further advance in your career, you'll really have to know all of the differences. But as of for right now, it's just not important. Okay. All right, so the next thing I'm going to talk about is a cardiac cycle. And the cardiac cycle this is where everything starts to come into play. This is where you start seeing, oh, okay, hold up. Your heart equals blood pressure. So if my heart is working really hard, what do you think your blood pressure is going to be? It's going to be higher, right? So they correlate, and we start seeing that when we get into talking about the cardiac cycle, okay? And the cardiac cycle itself has 4 distinct phases. All right, but we're gonna, because the atria, both of them there's 2 atria and 2 ventricles, and they have their own beats, right? But you also have to remember and think that we're just gonna keep it simple. We're gonna think of systole and diastolic, systolic, diastolic. Well, if that sounds familiar, it's because that's how we do blood pressure. We write our blood pressure systolic, 130 over 90, diastolic, right? Yeah. So that's where this comes from. And the easiest way to remember this is the heart at work. This is the heart at rest. Oh. So those 2 numbers are so valuable in blood pressure because it tells me. So if I see 220 over 110, what's that telling me? It's that heart's is working way too hard,
Yeah.
because my top number is high, and it's not having any time to rest because my bottom number is too high, right? So
Yes.
it really all starts to come into play, okay? So heart at work, heart
All
at
right.
rest.
So would that put you at like hyperactive? Like if it
It'd be hypertension. Yes, when you have an increased blood pressure, that's hypertension. That's one of y'all's words. The abbreviation for it is capital HTN. All right, and then usually we see with hypertension, people are also going to have tachycardia, which is an increased heart rate because the heart's working faster. And then if the heart's working faster, they're probably going to have tachypnea, increased breathing. So everything's at an increased level, increased blood pressure, increased breathing, increased cardiac. So all of those we usually will see. Now there are some type of medical emergencies where you'll see really odd things where your systolic will be real high and the diastolic will be low, and respirations and pulses won't match up. But those are all more complex reasons. But in average, yes, if somebody has hypertension, everything's working harder, okay? And basically it's working harder till it's not, and then that's not good. All right, baby, see what the air's on? I'm hot. All right, the cardiac cycle consists of all of the events that occur in one beat. So what does that mean? That means from the time the deoxygenated blood arrives at our right atrium, moves through and to the bottom right ventricle, on through the lungs, back into the left atrium, to the left ventricle, down through the body, and then all through the body. That's one complete cycle. And on the average, we normally have an average heart rate of 60 to 100 beats per minute. And they've dropped that because, so you'd want to put 60 to 100. They've dropped that because we don't want our heart working that hard. We want our normal not to be too high. So
Okay.
what are some things that could cause just your heart rate to increase naturally? You going to bed? Oh, um, I don't, baby. You just have to tell me. Thank you, baby. Turn it to 74. Yeah, that's way too hot. Sorry. um, so things naturally. Well, we know number one, stress is a killer,
Yeah.
and so if we have a long time of stress and your stress is repeated and it stays with us, it's going to affect not only our heart rate, our blood pressure, all of our other organs in our body. So yeah, stress can increase the cardiac cycle. Of course, exercise, well, exercise does it in a good way because we're
Yeah.
controlling and we're monitoring that, right?
Yeah.
Excitement. Yeah, somebody scares you, walks around the corner, clown with a chainsaw. Woo! Your heart's gonna go. We know smoking. Smoking, we know cigarettes are bad. We know that it increases blood pressure. We know cigarettes increase our chances of hypertension, cancers, and all kinds of things like that. So that's one of them, of course. And then lastly, fever. If you get a fever because you get sick or you get overheated because you're working outdoors, both of them things can cause a rise in your heart rate. That's very common.
Okay.
All right, I am going to post this to Teams. And this is talking about the heart sounds. And basically, with the sounds we listen when we auscultate, remember that auscultate is the what we call listening in the medical terms. So when we auscultate and we listen to some of a patient's heart, what we're hearing is a lub dub, lub dub, lub dub, and what that is that's the opening and then closing of the valves of the heart. The first sound is lub, and it's when the AV valve closes. Dub is the sound of the ventricles relaxing and the semilunar or the pulmonary closing. So like I said, I'll put this is really interesting. I'll post this for y'all.
Okay.
The next thing we're going to move on, we're going to talk about is electrocardiograph. And this is where things get what you call, they can become very confusing and seem overwhelming at first, but don't let them get to you like that, because it doesn't have to be intimidating. Okay.
Yeah.
So when we look and we think about our heart, we know that there's a beat, and this is basically us showing a beat but in printed form. Okay. So, and that's electric. So the electrical heart recording, graphing, right? So that's what it breaks down to. And we're going to talk about this. This is one complete heartbeat. And we're going to talk about the P, Q, R, S, and T. There is a U wave, but 17 years of being a paramedic, I never once saw a U wave. Now, I had a doctor who pointed one out to me in an ER. He's like, oh, look, a U wave. But I never saw one. So it's maybe it's not as common as what, but they added it just in case you ever did see one. You weren't like, what? All right, this is the second part, and I love Crash Course. I post a lot of their videos because Hank is awesome, and he goes through and he explains everything amazingly. So I will post this video as well to teams.
He's the one that talks really fast, right?
Yes, he is. Yeah, yeah. So I love all of their videos. Him and his brother doing them. Electrocardiography is, like I mentioned, it's the recording of the electrical changes in the heart. Now, here's I'm old school, so I'm still going to call it an EKG.
Okay.
But all right, new school, they're going over to ECG, and it's the same thing.
I never understood. I mean, why do we have to?
You cut out. I couldn't hear you.
Oh, sorry. Why? I mean, why is it that we have to name it ECG when we can just name it EKG? Why?
Because everybody likes to change everything. Some of them, especially in medical, because some things have multiple different terms for it. Just like the mitral valve is also called the bicuspid. Why? It just is. All right. So and a lot of times you'll hear doctors interchange them, right in mid speech. When I used to work for a transplant team, and I would hear doctors in mid sentence, talk about this and then go and flip over and talk about that, and it's just like, okay, so I got used to those being interchangeable, right? All right. So we do this test. Usually when you go to the doctor wants you to get one of these, or she wants you to get one of these as what we call a baseline. So what does that mean? That means you're healthy, you're feeling good. So your PCP says, let's get a recording of your heart. Because you're in your 20s and this and that. Okay, great. So when you're in your 50s, we can go back and we can monitor. So a lot of doctors do that. It's called a baseline EKG. So just to get a look and a feel of how your heart's working. All right. Now, of course, we use EKGs for other reasons too. If a patient's coming in symptomatic with chest pains or this or that, or so we'd want to hook them up. Usually, for me as a paramedic, when I did all of my pretty much any patient that got put in my ambulance, I was hooking up to an EKG just to be safe, unless it was something, completely like, a cut toe or something, an amputated toe. But, and then honestly, I'd still might put them just to, never know, shock, right? It's a wonderful warning system. It allows us to monitor our patient. So, like I said, and then right here, ECG and EKG are interchangeably. And the doctor who invented it is Dr. Einthoven. And he's the one that figured out, hey, if I put these electric charges, um, these electrodes on, I'm able to get and pick up the reading of the heart. And it's all actually called the Einthoven's triangle because you need the area and the width to be the proper placement to pick up the proper signal. That's why you see the lead placement when we start doing hands-on and learning how to put on the leads is so very important, because if you place a lead in the wrong area, you're going to get the wrong rhythm. So, and I have a perfect example of that. My daughter went in for a baseline EKG, and I didn't go back there with her, because she was 16, 17 years old, and but she comes out and their MA goes to the doctor and shows the doctor, and the doctor's like, oh, I'm going to refer her to a cardiologist. And I was like, what? So I'm looking at it, and they said she had some type of hypertrophy of something and this and that. And I'm like, well, I was like, okay. Well, first thing I do is I take her to the emergency room, because that's just me. I was worried. I wasn't taking no chances. So, because they wouldn't do anything. They wanted me to refer and wait. I ain't waiting. So I go over, well, it was actually urgent care. So we go over to urgent care, and we're in there, and the nurse walks in, and she starts placing the leads. And my daughter says, oh, you don't put them down here on your wrist? And me and the nurse look at each other. That's why her EKG was jacked up. So, because we limb leads, all of our leads for our chest, they have to be placed properly. Misplacement of them can lead. And I'm going to let you know, and I tell my former students this, as an MA, you got to be fluid. So you go someplace and they say, this is, I might train you to do it this way, okay? But then you get someplace and the doctor says, oh no, we do it that way. So you got to do what the doctor says. But the way I'm going to train you is the way that paramedics, ER doctors, cardio doctors, the proper way that they do it. And your limb leads go on the limb. Now, if somebody's a bilateral amputee, then yes, you could put it on the chest if you had to, because they ain't got no arms. Or if they don't have no legs, you're going to put it on the trunk. But if your patient has arms, you want, and you don't want it to be right over muscle. You don't want it on a large area of muscle. So you want it on the arms, all right? You want, and I have a diagram I'll be giving y'all. And for the legs, you want it further down, away from the trunk. And I'll show you the proper placement. And I'll post a printable worksheet and just I said Discord. I'm a gamer, so we use Discord. So I won't post it in Discord. I'll post it in Teams. What we're looking at when we're looking at an EKG is we want to watch and see the regularity. We want to make sure that when we see a heartbeat, that complex is what we call them, the PQRST. That one complex looks like the next complex, looks like the next complex, looks like the next. That's what we're looking for, because if that is, okay, that tells us right there, is it regular or is it irregular? And then we're also able to look really fast, and I'll show you a quick and dirty way to do a heart rate. Say you didn't have time, you can look at somebody's EKG and read what their heart rate is. All right. When you look at the sheet, let me see if I got a picture. Of course I don't. One sec. Well, heck. Let me go back. All right, one sec, because I want y'all to see what I'm talking about. this will work. So when we're and I'll get it. I'm not too worried about y'all actually learning how to measure, record, and read, because it is not your job as an MA to interpret an EKG. But I will give y'all some little side tips here and there to help you, just in case you want to know, because you can go and take your certification. You have to get a study guide and study it separately because we don't go that in depth, but you can get trained as an EKG technician, and it gives you another additional certification by doing this. But like this picture right here. All right, so an EKG paper is divided into large squares and small squares. One tiny little square is 0.04 seconds, okay? 5 squares, right? So we count 1, 2, 3, 4, 5 by 1, 2, 3, 4, 5 is 20 seconds. So there's math involved with this, and this is why some people go, ah, and run away. I know I am. I hate math. So but when we look at this, it helps us be able to, especially doctors, cardio doctors, regular doctors, be able to see exactly where that change is occurring. So this line that runs straight across the middle, and there's usually I'm trying to find one that stands out. I'll probably need to show you a 3 lead. That's right. 3 lead. Yeah. So usually what you're looking at is there'll be a line that runs straight across. That is called the isometric line. The isometric line is the line we want our rhythm to stay around. We don't want it all way up here and way down here and this and that. We want to kind of mellow in the middle, okay? So let me go back to this. So when we're thinking about that sheet of EKG paper and we're thinking about those complexes, what each one of them do is they tell us there is a like I said, please don't get overwhelmed with this because you don't have to know all of this. But there's polarity, meaning way back when you go back to science, remember certain cells are positive and negative and all that. Well, our heart rate and the cells in our heart run off of certain ions and calcium and potassium, this and that, right? So this changes polarity, and I'm trying to keep it as simple, like I said, as possible. But because of those changes in polarity, that's what gives us our waves and our signals that we're able to record, okay? Now, we talked about the SA node, which is the pacemaker. What happens when the pacemaker is signaled is that the atrial cells become depolarized, that the internal negative charge is reduced, and the charge inside and outside the cell is lost. That signals, and like I said, don't worry, you don't have to know this part, but what that does is that signals our ventricle in the next movement in the heart in the cycle. All right, so basically what all of this is telling you is that our heart's running off of not just an electrical, but there's chemical as well. And that's where it goes to that, the ions and the, calcium and potassium and sodium and so forth. All right. And then this is, if you want to, you can take a look at it. Like I said, I don't expect you to understand as an MA the polarization. That is a more advanced skill. But this gives you, so why we have a P wave. What causes the arc of the Q, what causes the tip of the R, and what brings us down to our S, and then what signals the T. All right, so it goes through. It's pretty cool. So, but this you do need to know. So let's talk about this. So one complex, one heartbeat, like I said, we call it a complex or a set, and it's a PQRST. Okay, so one heartbeat, the P is, like I said, the depolarization, the QRS, or so atrial, ventricle, right? And then going back to atrial, then back to a resting state. Okay, if that makes sense. And so it's kind of like, okay, atrial, ventricle, atrial, resting. Okay, now we're going to start it all back on over again. All right, this T wave is vital. This is a wave that, as an MA, I'm going to want y'all to pay attention to. This is the one that can alert you and tell you, ruh-roh, Raggy, something ain't right. So we watched this one, and I'll explain about that in a little bit. And this is more going along and explaining how the polarization occurs. But like I said, I'm not too concerned. But we know our first wave, you do need to know, is P. And then that leads to an arc of the Q, the top being R, and that bringing back down to an S. And then we usually have a space and then a T. Now, if you go on and you learn more about cardio, especially like EKGs and so forth, you'll learn that there's actually an exact amount of spaces that should be here. You know, and then there shouldn't, and if there's too much or too little, it could be a certain rhythm, right? And it means something's wrong. Or if this is raised too high, or it's depressed, or if this is too tight, or this space between here, every little thing tells us a key about the heart, okay? Our leads are the instruments that we use to connect to the machine and connect to our patient that read the electric wave. All right.
Put it on the charger so I can get there and over.
I need you to pause. If you got background noise, mute yourself, please. The pattern as far as like your EKG leads, we're able to see that, like I said, because we have the leads placed not only on the body, but they're connecting us to the machine itself. And this is what you would see if, and I put this image here for a reason. If your patient was an amputee, say they had no arms and they had no legs, this would be acceptable, okay? Now the way they got this is beautiful. This is perfect. But how we're gonna do this is we're gonna place anywhere in this area here. That right arm is gonna go in here. The left is gonna go over here. And yesterday, y'all remember when I told you, remember your patient's right and your patient's left. Because I'm looking at this, and when I'm looking at it, if I lift this hand, that's my left. So it's opposite. So you always have to remember that, okay? Patient's right, patient's left. So your limb leads need to be on the limbs, okay? And then what we're gonna learn is, this is what bone is this? This is the clavicle, right? And then we know this is the sternum. Let me check my time. I have a meeting at 10. Okay, I'm good. This is the sternum. And then these are our ribs. Well, the area between the ribs are called the intercostal spaces. So how we do placement of our, what we call our V leads or trunk leads, we're gonna find the patient's clavicle. I don't know, can y'all see my neck? You're gonna find the patient's clavicle, and then you are going to palpate or feel for the notches between each intercostal area. And if you like, this shows you. So we have 1, 2, 3, 4, and then right after the fourth, we're going to place V1. So we go straight down from the clavicle to the fourth intercostal notch and place our first lead. The same thing with V2. Find the end of the clavicle, go down to the fourth intercostal and place V2. Now you would think, what are we going to place next? V3? No, we're not doing that. So here's an easy way. The easy way is your clavicle, you're going to go to mid-clavicular. So that would be the middle of the clavicle. And you are going to go straight down right under the breast. If a woman, and this is where everybody's like, oh Lord, this is why we always wear gloves, okay? Because it's an intimate thing. We don't want to be hand to hand. That's inappropriate. So if a woman has a large breast, you may have to pull and lift up her breast to place your bottom V leads, okay? So, but V4, we find it by going mid-clavicular straight down. And what you're going to find is it usually lines up right under the nipple. Like once you move the breast, you'll kind of you notice that the nipple is mid-clavicular. Not in every case, because not everybody has the same nipple placement. So we place V4, and then we can come back, and in between V2 and V4, we smack V3, and it goes right along the curve. Men have pecs, women have breasts, right? But right along that curve. And then next, we're not putting 5 yet. Next, we're going to find the armpit, and that's the axillary, right? So we're going to find that axillary area, and we're going to go, once we've found it, we're going to feel down from there until we feel 3 intercostal notches. And we're going to place V6 right along the curve of the breast or the pec. And then V5 go right between 4 and 6 along the curve. Easy peasy. All right, we're not getting into blood vessels today. Thank you for joining me with lectures. Anybody got any questions?
Yeah, because I kind of got in a little late.
That's all right, April. I'm gonna post it to Teams so you can go back, watch the lecture, and once I upload it, you can pause it, take notes, okay?
Okay.
I have a question, Miss Gal.
Who's talking to me?
This Erica.
Hi, sweetheart.
Hey, I wanted to know, like basically because I was taking notes. So basically everything that you cover on here, we need to take notes on, or?
Well, I'll usually tell you, hey, you need to know this.
Okay.
When you hear me say that, that's when you should take a note.
Okay.
The rest of it, it kind of helps glue everything together.
Okay.
Gotcha. All right. That's how I think of it. Like, okay. Your nodes, your SA, AV, you need to know those. Okay. You need to know your chambers. You need to know how the blood flows deoxygenated to oxygenated, right? The main key, hitter, the big points, right? Lead placement, and then how we find lead placement. Those would be the things. But as far as like the depolarization and all that, I'm not so worried about that. That's why I said I'm gonna talk about it, but it's not, don't stress over it, okay? Okay. Anybody else? No? All right. No. Well, have a wonderful day. I am going to post the videos I told you I would post, and I'm also going to put a correct 12-lead EKG and a 3-lead EKG picture up. But right now I have my staff meeting, and then I have my next class with the lecture. So it'll be a few, but I'll get everything done. If you haven't done your survey
So
monkey,
this,
please make sure
so
you do
this le
so. Uh-huh.
so this lecture, I'm sorry, this lecture pertains to how to do the EKG.
This this whole lecture is basically the heart, its
Okay.
structure,
Okay.
EKGs, blood vessels, including
Okay.
arteries and veins, blood, and cardiovascular diseases. So we
Okay.
cover a lot in this mod.
Okay.
Okay.
No, I was saying this, when you were showing us the 4, 5, and 6, are those how
Uh-huh.
we go do the
That's a
EKG
yeah, that
placement?
would be EKG
Okay.
related. Yeah. Uh-huh.
Okay, yeah, that's what I was. Okay,
And we're gonna
okay,
go back. We're gonna
okay,
be dipping back into EKG. We just
okay,
I just brought it up because we're leaving a heart anatomy now, and we're gonna start
mhm,
talking about blood vessels next.
okay,
All right.
okay. Thank you,
I'm
Thank
so
you, Miss
glad
Carol.
you all
thank
joined
you.
me. Y'all have a wonderful day.
You too.
You too.
All righty.
Everybody be safe.
I'm also gonna post your project today or tomorrow. That way you have the entire mod to work on it and not wait last minute. Wink, wink, nod, nod. All right. Yeah, yeah.
I will whoop you, Miss Scalper. Okay.
Bye,
I'm gonna
guys.
get her.
Okay, thank
Okay. Bye
you.
bye. Have a
Bye.
good day.
Make sure
Bye
everybody hangs
bye.
up.
Okay.